Hello and welcome everyone to today's discussion. We're just going to give a chance for people to get on and we'll start shortly. Samantha Foster from HMA just messaged the chat. If you have any technical difficulties, you can message her and she'll help you get sorted. We're pleased to be joined today by our panelists. So I want to get out of the way as soon as possible and so we can hear what they have to share. So let me introduce my speakers from HMA's end who will be moderating today's discussion, and Matt Sandoval will be providing intros to our speakers in a minute. So I'm pleased to be joined by Matt Sandoval and Charles Robbins from HMA. Both are principals, and they've been county liaisons working with counties in California to implement care from the beginning of our training and technical assistance work. They both feel passionately about providing support to counties, and they have a lot of experience across the health system. Matt has done a lot of work with managing administration and operations and quality outcomes in hospital systems, and Charles Robbins has held different executive leadership positions with national and local nonprofit organizations providing primary care, behavioral health, and human services. So we're really pleased to have them join us today. A very brief outline for today. We have these introductions, and Matt will lead us through those, and then we'll have that cross-sector collaboration panel discussion. As we go through, we have some scripted questions. We want to be gathering questions in the chat as well. So if you have questions that you'd like for our panelists to respond to, we certainly hope we can get to open questions. And if not, we can follow up afterwards and see what our panelists have to share. So with that very brief introduction, I want to turn the time over to Matt to introduce our speakers. Matt?
Thank you, Patricia. I'd like to introduce our panelists from San Diego County. I'd like to introduce Christopher Guevara, Interim Chief for Behavioral Health Services, Project Management Office, and Scott Brown, Superior Court Special Projects Manager, responsible for the creation and of the collaborative courts and the self-help clinics, among many other duties assigned to him. And from Tuolumne County, I'd like to introduce Tammy Mariscal, Behavioral Health Director for Tuolumne County, celebrating her 35th year in behavioral health services. So congratulations. Brock Kelly, Deputy Director for Tuolumne County Behavioral Health, and Stacy Robbins-Pavin, Court Manager and Investigator for Tuolumne County, overseeing the collaborative courts. So thank you all. And Samantha is posting all of the bios in the chat for you to review. With that, I think we'd like to start our discussion, which is why everyone's here. We have the list of questions for planning, and I will be leading those. And I'll start with Tuolumne County. What were your key elements of your cross-sector collaboration that occurred during the planning phase of implementing CARA?
Well, basically, we did an extensive amount of planning for the first 6 months on CARA Court with our partners. We met with the Superior Court, with social services and other agencies to really try to see how this CARE Court would best be put into place. So I can't say how much setting aside planning time to at least weekly to go over and review how CARE Court would be implemented.
I could add to that. Tuolumne County is very unique in that, first off, we're a small county, and so we were able to build upon our previous relationships with our stakeholders, and we capitalized on not only those relationships, but the relationships our stakeholders had as well, which assisted in bringing additional stakeholders to the table. And as Brock mentioned, we started with weekly meetings and really kept those going for about 3 months, all the way up to the October 1st implementation date. And I really think that those relationships assisted in us lifting up our implementation effectively and quite swiftly.
And I think one of the important things, like Tammy was saying, was those weekly meetings. It's COVID helped us do a lot online and a lot by Zoom, and so people could come in and out during those times. At least in the earlier stages, if it can't be weekly, having it, you come back to your individual teams, build some things, and bring them back to the table with your partners. So that was really, really helpful. And we still meet in our court on a monthly basis to kind of review where we're at with things, if there's system changes based on what we hear from our partners.
San Diego County?
I'll go ahead and start. In San Diego, we've been collaborating for a long time in criminal justice and in other case areas within the legal system. And then we often overlap with behavioral health and healthcare and some housing periodically. But I think some of the things that helped us earliest were understanding the differences between the court and healthcare and behavioral health specifically. So we know in San Diego, we're a big court with 4 big divisions, and we basically have 4 different court cultures with legal cultures around us. So we have our own issues internally as a big court, but then when you add in behavioral health with its own culture and constraints and processes and pressure points, I think just understanding the differences between the court and legal culture and behavioral health and healthcare really establishes a foundation for understanding and then being able to leverage the advantages of both sides to that. So kind of in doing that, we started looking at the standard language from the CARE Act. Judicial Council has the definitions. There's several different processes you can look at for how cases will flow that people have done. And we tried to adopt, that language and make sure we're very distinct in a CARE agreement versus a CARE plan, and an initial petition versus an initial hearing and a follow-up hearing, to make sure that we're all on the same page. And in doing that, we wanted to make sure we established our roles and responsibilities in a way that we didn't overlap each other. We tried to avoid lane changes. The court's here for a specific purpose. Behavioral health is there for a broader purpose, in helping people, but we want to make sure we work together. So where there's overlap, we want to find common ground and make sure we're moving forward in the same direction. And then the last part of our planning was up to each agency that's involved. So we have the public defender, we have behavioral health, we have a mental health provider, a nonprofit in the county, and then we have the court and county counsel. But what kind of happened, and I don't know if it was intentional or not, but what happened is we put the right people in the right places. So our judge is an experienced drug court judge. She's also a family law judge, a family law specialist in her previous career. So she understands the issues in front of her and understands, sometimes people are going to do what people do, but you just need to try to keep on the same track with them. And so our group also includes the county counsel, who has collaborative court experience. Our public defender has extensive collaborative court experience. So they're accustomed to working with each other, and that really helped our process move along, I think, quickly.
And so I'll just, quickly add to that in addition to having all of the right folks in the room looking at this new process, one of the things that we really aim to do from a project management perspective within BHS was to try to simplify this as much as possible, keep things in very visual dashboard, one pager, to make sure everyone was in alignment coming from all of the different stakeholder groups.
And that does take a lot of meetings. We also had a lot of meetings like Tuolumne, a lot of awkward meetings with a lot of people on them. But you work through it. Always have fun when you're doing it, right?
Thank you all for your responses. The next question is geared, I want to start with San Diego. It's really just when you look at the planning process, your internal and external stakeholders that were important to have at the table. Can you describe that process and how that was decided?
So from the BHS perspective, I think we're a unique county in many ways, and BHS for San Diego already had an existing project management office. So definitely working with stakeholders and thinking about things from a project perspective is something that is very familiar to us. And one of the things that we leveraged with our former chief of the project management office, Jerry, had put together was stakeholder mapping. So working with all of the different organizations, including the state, one of the things that we find is you're often getting agreement with leadership, but then you're working sometimes with the tactical folks, or sometimes several steps down from the folks who you got agreement with. And that communication is not always perfect. And so just having an understanding of who you're talking with, where they sit in the organization, definitely something important, and something that we focused on from a project management perspective.
Follow up for our court perspective, our planning worked with internal and external. We focused kind of on 4 key areas to the implementation of the CARE Act. We knew there was going to need to be a self-help and education component because this is brand new and we're just learning it. So the general public is even more confused about what it is and what it isn't. And honestly, when they read the papers, they think it's a lot bigger than it is. And so we knew we would have to implement a good community education and engagement process and establish self-help clinics or expand our existing self-help clinics. So we worked with Legal Aid Society on that, and they've been fantastic. And we used some of our CARE funding to support that. We also focused on our court processes and procedures. So our operations people, when a petition comes in, where is it delivered? We will accept them in all of our 4 main locations, but they're going to be sent centrally here downtown San Diego. So what does that process look like? And we kind of mirrored our existing mental health process for petitions, and built some things around that. We also had to establish internally kind of a general order of petitions can be filed anywhere. They're going to be heard in department, 1402 or 1202, 1203. It's changed already. So establishing those things internally and externally, we also we knew we needed our case management system to have a component for CARE, which was done pretty quickly. We're in Odyssey County. And then, what are we going to do with our funding and how can we best resource the money that's been provided to implement the CARE Act and where are our needs? So that was our internal focus for the court, and then with that little piece for our customers.
Thank you. Follow me?
In terms of the court in Tuolumne County, we also had to figure out a lot of those internal processes. And so when we're developing these forms, it all literally boiled down to what if somebody walks in the front door? Who are they going to engage with? What does that process look like? What pieces of paper do they need? Where do those pieces of paper go? And as you begin to ask yourself those questions, you identify all of those internal players that need to be a part of this process to work out any kinks that there are. I know a lot of the courts with the changes in budget gave some of their CARE money back, is what I heard, but we did utilize our money to bring on a CARE coordinator, and that person works directly with the self-help department and is available to kind of troubleshoot questions that community members have when they're looking at these forms. What does this mean? In a very, unbiased, from a very unbiased perspective. And then also having those relationships with behavioral health when somebody walks in who doesn't necessarily have the right diagnosis, but they're, it's a mom saying, my son is bipolar and he really needs help. Being able to pick up the phone in a small county has been kind of a big deal, and saying, okay, well, the court's not going to necessarily be able to help you. We can't give you legal advice. You can fill out this form, but also there's this other thing. So we've incorporated a lot of behavioral health brochures into our self-help center, in addition to all of our CARE Act paperwork. We are an e-court court. Our IT manager is more than happy to give your e-court folks any information that they need. So you can definitely reach out and coordinate there, but building CARE into the case management system that we have, that was definitely a big project.
I'll speak to, I appreciate Christopher's point of highlighting what a big deal care court was to the general population. There was varying degrees of interpretation of the law, who it would help, who it wouldn't help. So scaling was important. So our stakeholder process, to get everyone at the table, we started big. So we scaled our strategic plan with bringing anybody to the table that wanted to be at the table. That included our NAMI representatives, law enforcement, food banks, shelter, our courts, of course, all the obvious stakeholders. And upon our all becoming more familiar and comfortable with the language that 1338 held, we began to scale down. Individual entities understood their role and were a little less heightened around that. And so our core planning team really became what you all probably are starting with. It's your courts, it's your behavioral health, it's your county counsel. We had our public guardian come to the table because LPS was something that was held out as a potential outcome of the hearings. And they also kind of sunsetted their attendance of the frequent planning and understood that they possibly would need to come back to the table, but we're able to scale back as we learn. So I think scaling is really important. Listening to your community, bringing everyone to the table is really a good way to begin to settle down your community. So you can begin to have a shared understanding about what care court will do and won't do for your community. I don't know if you have anything else to add, Rob. Thank you.
Thank you all. And the final question around planning is really what roles did you use or create to facilitate cross-sector collaborations, such as liaisons, coordinators, court case managers, etc. And we'll start off with Tuolame's response.
Basically, kind of like what San Diego had mentioned earlier, is identifying the key people that will fill the positions to provide the service was really important. And so in our small county, we had also been doing forensic services through mental health diversion with the court, drug court, etc. But we hired a psychologist, because we didn't have one at that time, that would focus primarily on the evaluation and assessment process for these clients. And that has been invaluable. We could not have really done the type of assessments that we needed and be able to provide what the court wanted, the scrutiny, without a psychologist on staff. And then in addition, we created a position with a program specialist to focus on forensic. So we had a forensic program specialist. We had someone who could deal with the legal, tracking the very clerical aspect of legal stuff, such as serving clients, coordinating with the court, picking up court paperwork. So by setting the small team that would deal with this, we were able to be successful. And it was a surprise to me as a clinical deputy director was that the amount of scrutiny on diagnosis and assessment by family members who were in petitioners, by the court, was much higher than previous legal programs that were involved with mental health or substance use. So we really had to up our game to be able to say, this is why we are saying this person has schizophrenia and spectrum disorders or does not have schizophrenia. And they wanted, we weren't required to be expert witnesses, but we are reaching that level of expertise that we had to justify why we are recommending or not recommending these services.
I'll follow up to that. In addition to those positions that we have now on staff, we also plan for a legal clerk. That was really identified as necessary because of the potential LPS outcome that's within the law. We had quite the difficulty identifying an individual that was wanting to have that type of work. So we have sunsetted our efforts towards that classification and have been very successful using a staff services analyst classification to manage not only the court papers and the various tracking, but also to serve the respondents. and it has worked out quite well.
In terms of the court, like I said earlier, we have that coordinator. We already have the existing collaborative courts with the drug court and the dependency drug court. And because we're a small county, it became another hat to wear. So we do have, there's 2 of us that do investigations and coordinate those programs. But yeah, that's about it. And then I think the burden really fell a lot on behavioral health, what Brock was saying about the level of expertise that's needed. You know, you're asking judicial officers to look at paperwork and truly understand diagnoses, and that's not where they went to school. So we're very, very grateful for behavioral health employing that and being able to make that palatable to the bench.
Thank you. San Diego?
I'd say for the court, I became the liaison just kind of because I already knew a lot of people at behavioral health and at public defender. And so I became kind of the person that would, you know, we would talk things through and then go to the bigger group to make sure everybody was on the same page and agreed with how we were going to proceed with things. So I became the liaison in addition to all my other duties, and it's kind of worked well because I've been here for so long. And understand what judges generally want and what operations generally needs, and what our administration wants as well. And kind of our from the get-go, our presiding judge said, you know, this may not be the perfect law, it may not help everybody, but we're going to do everything we can to make this work. And it won't be because we dropped the ball somewhere. So that was kind of our mission, is to try to make sure that, you know, nobody falls through the cracks. As many people as possible can be helped who are interested in being helped. And so, you know, we didn't hire any additional people, but I know San Diego County Behavioral Health added or deployed, I don't know if they added, but deployed people to this who I think they knew were working in the right positions, right, Christopher?
Yeah, to you know what Scott was saying earlier about having the right people with experience, I think that was something we were really lucky to have for every stakeholder group, having the right people come together with the knowledge to get things done. The San Diego, you know, is a little different. We ended up growing out a new care team with 38 individuals. And a lot of those individuals were coming from internally already, you know, within BHS, but hired folks to also meet the need. But it was pretty large growth, pretty fast, and having folks who are already familiar with BHS, already works either under or with the county or in our system of care, I think has been critical to being able to ramp things up really quickly. And then, of course, as Scott was saying, on the court side, you know, very familiar, very experienced, as well as with our public defender and county counsel. Everyone came together and was able to do their part.
Thank you all. Well, this concludes the planning questions, and I just kind of like to thank you all. And I think some key takeaways really are just, sounds like having the right people at the table and knowing when to convene and knowing when not. And you know, it seems like both counties succeeded in, you know, figuring out when the team needed to kind of get smaller to resolve some of those other issues and then get back bigger. So really, really appreciate that. We're going to move on to the court behavioral process and workflows. And with that, I'm going to hand it over to my colleague, Charles.
All right. So the first question regarding process and workflows, how were other stakeholders incorporated into workflows, especially the collaboration between behavioral health and courts? So why don't we start with Tuolumne?
And I'm going to punt to Stacy.
Okay.
Well, we've had to actually change the way things go since implementation. So, you know, once we went live, we were like, oh, this isn't going to necessarily work, or this does work, because we've already had those natural partnerships through the other courts, through mental health diversion, with DJ, all of those things. We started there. and that became the foundation for how we communicated. And there's a lot that we don't do in our small county, but we're going to get there one day, like e-filing. So when a petition comes in, it comes in paper and it comes straight through the window through a legal clerk. And we actually used email to let our justice partner know, hey, there's a new petition. Here's the case number. And folks have access to eCourt to be able to look that up, county counsel. Behavioral health literally sends somebody in a vehicle to drive over to pick up or drop off documents. And then as we realize that maybe there's kinks in there, or maybe the timeliness of documents or those, needs to be turned in within X amount of time or X amount of days, we've had to make some minor adjustments there so that, we're still even as of a few weeks ago working out how to smooth things out in that direction.
Thank you, Stacy. Brock, anything you want to add? All right. Let's go to San Diego.
I think that's a great statement Stacy made. We're still working out the kinks. Every new petition is a new situation for each person, I feel like. But the one thing we have is we have definitely incorporated our stakeholders into the courtroom team. So we kind of, upon rollout, it's like we need to focus on what's going to happen in the courtroom with those petitions. And behavioral health has its own huge lift for these, moving these petitions forward, finding the person, assessing them, making sure trying to engage them, trying to develop trust with the person at the same time, but also trying to do a very technical and highly professional job of trying to figure out what exactly is going on. And so I think our stakeholders were primarily just trying to make sure our workflow internally was smooth. And then, like I said earlier, when we did overlap with behavioral health, sometimes making sure we're doing some functional threading, make sure we're not duplicating work between each other, and then, just finding the right way to move forward with it. So our stakeholders started with just the courtroom team, I'll say, behavioral health, county counsel, public defender, and the judge, and the court operations staff, clerk and back office. And then now we also, at the same time, are trying to stand up self-help and make sure that, where are people going to come in? Will people come into your courthouse? Will a family member, a first responder, a person living with the person, the respondent, do they want to come into the courthouse? Is the courthouse a friendly place? Will they want to be somewhere in the community or in a clinic? And so, working on that piece at the same time and trying to set up a system where we have a concrete plan, but we also know we're going to need to adapt because we don't know what we're going to see. And so we've been constantly adjusting the past 7-8 months, trying to analyze, draw data where we can in order to figure out where are our stakeholders coming in. They're making more phone calls than we see, than they do come into the courthouse. But we are seeing a lot of people come to the courthouse for self-help too. So working on those workflows and just kind of, be flexible with everything.
Thank you. Christopher, anything you want to add?
So just to expand, I think Scott very eloquently put together the court component, but outside of the court, BHS is also working on workflows for people reaching out to one of our stakeholders. With Legal Aid Society, we also contracted with them to help support individuals asking questions about the care process. And then, of course, with our treatment providers and making sure all of that flow is as seamless as possible. And to Scott's point, it's a process and we're continuing to refine as we go.
Awesome. Thank you. So let's stay with San Diego. How did you facilitate necessary data information sharing between behavioral health and the courts? And, speak to any automation that you created.
So data is a big deal for San Diego BHS. We invest a lot in it. We focus a lot in it. And I can share, from the BHS perspective and looking at the legislation, we really started with the data components in mind and looking at the care process as a court process, as a clinical flow process, and a data collection and reporting process, all having to overlap. So one of the strategies we put together to simplify and streamline pieces for all individuals involved was we templatized our all of our court reports, the things that we were submitting to the court, to make sure that when they're looking at investigation reports and things like that, they're looking at the same kind of documentation for each client. We're continuing to refine those pieces as well, but I think that was a big part of data sharing between us and the court.
And from the basic process part of it, there is the county established a SharePoint site with very limited and restricted abilities. So the court, being we're kind of one of those courts, I'll say we're one of those courts. We will electronically send out information, but we want hard copy back. So when we get a new petition and the judge reviews it and it's approved, she will click the button and her clerk will send it through the SharePoint. So BHS knows they have a new petition and they have, 15 days or 14 days to look at it. And we will also send out notices that way. So we do electronic noticing, which is kind of like email, into a SharePoint site. Like I said, it's a Microsoft thing. It's the cloud, as it were. But it's completely safe and locked down, so there's no public access to it as well. And so, like I said, we will share information. The court will electronically, but we demand hard copy in return, unfortunately. So, at this point, we're getting there supposedly. I've been hearing about e-court and things, paperless systems for 30 years. So maybe we'll get there.
Fingers crossed. Thanks, Scott. All right, Ptolemy.
One of the things that I'd just like to point out, like Scott was saying, we demand paper back. We're all paper in our county. So making sure that you address any nuances when that petition comes through, what does that look like? How do we ensure that doesn't get lost? Because even though it seems like relationships are pretty good and there is grace there, the law is pretty rigid about timelines. And so making sure that that piece of paper gets through the court in a timely manner so that the communication happens with behavioral health, however it is supposed to, whether it's SharePoint or email or whatever. They only have a certain amount of time to find people, to engage them, to do an assessment, and to get them to the courthouse. And so asking all of those questions is really, really important to find those processes that work best for your court.
Awesome. All right. And how are those being served to the respondent?
In Tuolumne, we are utilizing our staff services analyst as our serving the subpoenas.
Yeah, it's a behavioral health function. So the person that goes out to engage the person will serve them with the petition and everything else.
Okay.
Tuolumne chose to not have that be treatment providers, case managers, nobody that was possibly already involved in the respondent's care, and wanted to make a clean distinction between the roles.
But kind of back to the previous discussion of how having experienced staff who can do this in the right way, because you're basically trying to form trust with a homeless person and you're walking up to him saying, I'm also serving you for court. That is how you say it. And so we've had definitely some great scripts in how people approach people to make it not threatening and explain what care court is, provide some education to the client, and try to convince them to engage in this civil process.
All right.
And also, we've also served people in a variety of settings, because as you know, a lot of people who are homeless or struggling in the community with schizophrenia move around to different situations. So they may be in the jail at one point, then they're in the hospital, they're in their parents' house, they're on the street, and then they're in convalescent for some reason. So there's just a whole variety of situations we found ourselves as we're trying to locate the homeless person and then serve them, as well as traditional homeless camps and stuff like that.
All right. Thank you all. All right.
I'll quickly add, in San Diego, our case management assistants serve, so the clinician doesn't have to serve their own.
Okay.
And we also try to coordinate the public defender's visit shortly thereafter the initial visit with the case manager clinician.
All right. Well, I'm going to turn it back over to Matthew for our final questions.
This is going to be regarding service delivery and coordination into and out of care. We'll start with Balame with this question. Describe any strategies for cross coordination between stakeholders for respondents that are entering into and going through the care process.
We primarily use an intensive case management model like full service partnership with to provide intensive services to link them to these different partners. And regardless of whether they qualify for Care Accord or not, we're trying to do the same aim as Care Accord, is help people get off the street, get into whatever services that they need, and reach the partners, whether it's eligibility or other medical care or mental health care, to get what they need.
Stacy or Tammy, anything to add?
I have nothing to add. Thank you.
No, I think that's about it. Is working with the FSP type model.
Thank you. San Diego?
Say talk a little bit about our coordination. So we have our experienced behavioral health team, mental health clinician, our public defender. They're really working together on every case and trying to figure out what are the things that the client needs, what might motivate them to engage with this and not just say, I don't need it, I'm fine, I'm happy with how my life is going. So our team, our public defender and the county counsel and behavioral health have weekly meetings before the court session. They talk about the cases that are on calendar. What can we expect? Is this person, going to be a great candidate for this process? And if there's a challenge, what do we need to do to motivate them to stay with this process and engage? Because we often have, a family member who is just beside themselves. They've been dealing with this for 10, 20 years, or even a short period of time where it's a late onset of the mental health. So it's really impressive that our public defender, the county counsel, the mental health clinician are meeting the day before, and then with the judge, they meet for a half hour before the court session and just kind of talk about everybody. We will allow people to appear by video as well. We try to be as flexible as possible. So sometimes people are in the courthouse and are at the court hearing, and sometimes they drop in by Microsoft Teams. And so the clerk has to control the in and out of that, which is complicated sometimes, but making sure everybody has their time with the judge, can speak about what's happening, their experience. We've had petitioners that are mothers and fathers, and their child won't engage. And so they talk to the team about what might help motivate the respondent to engage in this process and in treatment. So that's the coordination piece of it that I'm particularly most proud of, I think, in our county, is just the ability to realize that this is an opportunity, it's a tool. It may not be for everyone, but we're going to do whatever it takes to try to get the person assistance. And if they don't qualify, what other programs might there be for the person as well?
So I'll just add that the effect that all of that working together has had for us has currently we're 100% care agreements. We've gotten folks to be able to connect. We have not had to go through the care plan route to this point, and we're 100% care agreements.
Thank you. And the last question before we open up to Q&A is, and this is going to start with San Diego County, is just describe any innovative solutions you've identified for collaboration or collaborating across agencies, departments, providers, or existing programs.
So one of the pieces that's kind of, again, unique to San Diego is we also have our public conservator's office under the behavioral health umbrella, and our public conservator office is kind of the sister team to our care team. And so we've been able to leverage care as like a step down option for public conservator cases sometimes. And with all the petitions we've received at this point, about 8% have been internal, and most of those being like step downs and alternatives to public conservatorship.
Nothing for me.
That's Walme.
Gosh, I'm thinking that one of the things that, again, us maybe a small county symptom is we've been able to work with our partners that work with mental health diversion and our felony IST, and somewhat in way, shape, or form, it's almost become maybe a nexus to care court and a possible option or off ramp for individuals involved in other court proceedings that has a mental health or behavioral health component to it. I'm not if Brock or Stacy wants to elaborate on that. Just that's a little teaser.
I think it's interesting that these clients move in and out of different legal statuses. So they may be on a past probation, which has expired or not. They may be referred both to care court and felony diversion, and then felony diversion begins to take precedence, or they may be on diversion and care court. So, and then we go, as we're mentioning with San Diego, like you have the LPS clients who are being stepped down or considered for conservatorship. So that was kind of a learning thing for me. We had developed work with all these programs, but the fact that they're crossing all these different legal statuses, and what's the best program the court's looking at, where do they belong based on the circumstances. And so it's definitely having, it's nice being a small county in that regard, we're having an integrated team that's doing a little of all of those tasks. But it's definitely an interesting status for the client, and we're working with the public defender as well. Like, where is this person ending up legally?
Like what Tammy said, we are a small county and we have a set amount of providers. There's other Cohort I counties that do use a lot of CBOs in their existing mental health systems. And I think what was really cool about San Diego is, like you said, there's 100% care agreements, and you haven't had to get to that plan point. I know other Cohort I counties have utilized their CBOs or leveraged those existing relationships. For example, folks that, housing as a part of the care program or the CARE Act is making sure those basic needs are met. And there are other counties with CBOs stationed at their homeless shelters, which become a natural part of that care agreement. So when somebody is referred to care court and they don't have housing and they're sleeping on the sidewalk, they're able to get them immediately connected to the homeless shelter where there's a CBO that's stationed in that shelter. So there's some really neat things.
All right. I think that gets us to the point where we can open it up for some questions from our audience. There already have been some questions, so let me start with those. So Domingo in Kings County is asking, would you please let us know who the lead agency/stakeholder that facilitated the interagency collaboration during your journey on your implementation? So who, anybody want to? Tammy, go ahead.
Okay, thank you, Charles. Our CAO of the county led the full county implementation team. So that was at our CAO level, and the core planning as far as internal processes and other stakeholders, it was led through our Health and Human Services director at the time, who brought all the stakeholders together.
For San Diego, I'd say our behavioral health director, Luke Bergman, really started reaching out and ask, what's this going to look like? Who's it going to be? What's the court process going to look like? And so we started talking early on in 2020, calendar 2023, with that, and then adding more pieces to the puzzle. Our assistant executive officers involved, director of operations, myself, the judge, heavily involved in getting this moving to make sure we're doing everything we need to do to plan and be ready to go when we had to start on October 2nd, since October 1 was a Sunday. So it was really our behavioral health director, because honestly, the behavioral health has the hugest lift on this.
Thank you. Thanks, Scott. All right, our next question. Have Cohort I courts developed any local forms to facilitate the court process? For example, for the supporter role or when the care petition is denied?
For the court process, we do have some court minute orders that were developed. I think there's 2 or 3. They're on the Judicial Council share site, I believe. And then for we don't have a lot of supporters right now. Oftentimes we have 50% of the parents or the people that submit the petition. They will want to stay engaged, and as long as the respondent is okay with that, they can stay engaged and try to support things along. We do have a couple other supporters, but we don't have any forms or any training. We were relying on the statewide training for supporters. And then the other part of that was the forms, and I lost my train of thought.
Like when a petition is denied.
Oh, I was going to say what we do in San Diego, which may be different in each county, is when we receive a petition that isn't quite 100% have everything, but it's close, the judge will continue it for 30 days to give the person time to add to it. Like if they don't have some sort of healthcare documentation or something from a doctor regarding a previous hospitalization, they will let it continue for 30 days instead of just straight rejecting it. So the person would have to start from square one again. So they try to make sure that if there's some deficiency in the petition, the judge will give them time to amend it.
I'll also add for individuals who are dismissed, our team did develop a dismissal letter to send out to petitioners and respondents, along with customized resources based on individual needs.
Okay, great, thank you. So I want to ask about any business agreements or MOUs between the courts and county behavioral health. Anybody want to describe that?
I don't have any.
Okay.
It's behavioral health is a party to the case essentially, so we can't have an agreement with them necessarily. And the judge is making sure behavioral health is doing everything they can do. All the other support people are involved that we can, so there's no side agreements. We have an agreement with legal aid for self-help, as does county behavioral health for a different component of the self-help piece in education.
Okay. And then there's kind of an adjunct question, thinking about information sharing. When can information sharing start happening?
It's information sharing there's really no information sharing unless you're a part of the case. So county council, behavioral health, court, are you talking about aggregate information?
Well, I think this was mostly related to MOUs. I think we're good. Another question is, how many clinical evaluation review hearings have been held in each county?
That I'm not actually too sure of. When we have a petition that meets prima facie that is missing maybe some of those necessary pieces, the evidence of the 5250 or something like that, we send that case over to behavioral health and say, can you please prepare a report? They do an evaluation, submit some pretty good reports. Our court has been very impressed with the documentation that they've provided us. And then we have evaluations based on that. I think we have one case where we've sent it back and requested some additional information. The prima facie finding and our local form for that drives that piece of information sharing in accordance with what the law says, that you have to provide these records, and then all of those come back to the court for review.
Okay, thank you.
So in San Diego, we haven't had any court-ordered clinical evaluations, but the team is telling me that we've completed 3 evaluations because of diagnostic uncertainty.
Okay, all right, thank you. Another question, has behavioral health shared information about the respondent with the court?
I'll speak from a privacy standpoint. We are behavioral health only shares information through our evaluations and reports to the court. No other records are shared during to the court or through proceedings otherwise.
Okay. And there's a question about has behavioral health provided transportation to court for respondents or any other agencies assisting with transportation?
Yes, and Tuolumne Behavioral Health does provide transportation if the client is willing, and that's a big part. Otherwise, sometimes they do have a supporter that will transport them, but it's pretty rare. So usually these individuals are homeless without access to the court, and so that's a pretty important component.
Thank you.
So for San Diego, we support with transport, either our team or through telecare.
Okay, great. Would you please share your process if someone is homeless and needing to be placed in housing or bridge housing based on the severity of their mental health conditions? This is a little bit less of cross-sector collaboration, but a question nonetheless.
Well, basically, we provide in Tuolumne the intensive case management to try to offer housing when available, and or get them into bridge housing for these homeless individuals. So that's a big focus. I mean, and yet it's interesting that not everyone is interested in housing. So definitely, I would say more than 50% are not interested in housing. So it's more of a relationship building with the homeless individual and trying to get them to see what they would like and whether they would be willing to enter some type of housing in the future.
And similar for San Diego, we do refer to short-term bridge housing, typically able to get someone housed within a day or two. Similarly, many are not interested.
All right, thank you. I've got one last question before I turn it over to Patricia to close us out. What happens if the petitioner does not have medical information to support the petition?
Well, it's really up to the judge. So if there's enough other information in order to give the petitioner time to gather that, then they'll give time. But if there's insufficient information, then they can't make a determination, and it'll be, it doesn't meet the criteria.
And if the judge determines that they have enough information, like you're saying, to meet prima facie, then they assign behavioral health as the petitioner, and then we do a more thorough record request from different hospitals, agencies, and treatment providers. So we do a lot of that, trying to find out information. For example, we'll get a very vague, like this person was hospitalized in San Francisco in 15 years ago, or this person was getting treatment at a clinic somewhere in this city. But actually, we've had pretty good success at getting some of those records when they still exist. Other times in the distant past, they've already been shredded. So, but that's a lot of that, trying to do that within a short time frame. Okay, we need this within 2 weeks in order to get to court to make our report. Has been a big focus.
Thank you. All right, Patricia, why don't you close us out?
Thank you, Charles most recently, but Matt as well, and of course all of our court and county panelists. We have a lot of great information about cross-sector collaboration and some other questions from the group about things that they're working through. So we appreciate everyone sharing your experience and replying to some of the questions from the group. So really appreciate your time. As far as next steps, please take the evaluation after this training. It'll pop up. There are a lot of questions coming through about different things. Please feel free to email info@careact.org or your HMA county liaison with clarifications, questions, technical assistance requests, or to get answers to some of these questions that you're not sure where it should go, but you want to follow up with it. So please feel free to contact us there. If you're not already, please join our listserv. Sam is going to post these links in the chat. But our listserv is where we put out notifications about upcoming training, open forum, and other TA activities. So please feel free to join that. And then counties, you've likely been speaking to your HMA liaison about the implementation resource guide. We have some updates that we'll be releasing soon about a number of topics and some lessons learned that we've had and some additional training links. So if you're interested in getting that update, ping your HMA liaison, although they will be communicating that to you as soon as it's available. So appreciate everyone's time, and please reach out if there are any questions, and we'll route you to the right answer. Let me go ahead. I don't see that we've gotten our email address in there, so let me just put it in the chat before you go. If you aren't sure where to go and you need help, email that email address and we will get you to the right place. Awesome. Thanks again to our panelists, and let us know if you have any questions.